Hello, everybody, and welcome back to joining us on another episode of On Call Medicine. Whether you're watching us on YouTube, whether you're listening in on your favorite podcast app, we really appreciate having you with us. And if you want to get notifications as to the next episodes that we're going to be producing, you can always subscribe. That way you get the notifications, and we just appreciate having you join us. And don't forget to hit the little follow button down below. All right, joining me as always, everybody's favorite, Dr. Todd. Welcome back.
Thank you, Phil. I don't know about everybody's favorite, but hopefully a few people's favorite.
I know of at least one or two.
Maybe a couple.
Maybe a couple.
Yeah. And I
We'll
hope,
build on that.
Actually, I hope some of you maybe are watching. Definitely let me know if you're watching this, and if you are a patient of mine, I would love to hear from you. Let me know if this is helpful for you as well.
Absolutely. So today, I know we're going to be talking about a topic that is, it's going to hit home to a lot of different families because whether directly or indirectly, I know a lot of people are going to be dealing with this or have known somebody that's dealt with this. I know from my own personal family, we've had folks that have dealt with this, even if not immediate family. So I'm definitely looking forward to jumping into a discussion about diabetes.
Absolutely. Diabetes is definitely bread and butter medicine. This is something that every internal medicine doctor, primary care doctor, frankly, even specialty doctors should have a pretty strong awareness and understanding of, because it is so prevalent. I mean, I don't have the raw data offhand to tell you maybe how many millions of Americans live with diabetes, but I can tell you the number living with it is actually far higher than we even know. And that is because of, and if you tuned into our discussion about the role of primary care, maybe one of the takeaways from that was getting in with your doctor, frequently, getting screened and checked frequently, because sadly, diabetes goes undiagnosed for a long, long time. And actually, another interesting fact is it usually takes 5+ years of undiagnosed diabetes before symptoms will start to set in. And that can vary depending on the severity of the diabetes. But the idea is that a lot of people won't know it and won't know it maybe for several years.
Well, that's really good information to have. Now, let me just ask, from the viewpoint, I should say, of somebody like myself that I've not dealt with diabetes directly. Let's just say I'm a patient of yours. I've seen you a few times. We're building up that patient relationship, doctor-patient relationship we talked about on the first episode. If I'm wanting to get a little bit more familiar with diabetes, how it works, the kind of things that I can expect having that, what are some of the things that we can really get into and to understand how diabetes is?
Yeah, absolutely. And I think, too, kind of piggybacking off that a little bit is if you're watching out there and you're thinking, well, hey, why does this apply to me, right? I don't have diabetes. Maybe I don't necessarily have an immediate family member with diabetes. So should I bother listening or tuning in for the duration of this episode? And I would say, well, please do. I mean, we hope you do, and
Please do.
and partly because, though, I think some of the tactics that we talk about in terms of how to improve diabetes, these are going to be fairly universal. These are going to be strategies that are going to help improve really your overall health anyway. But I suppose on the other side of that coin, and you mentioned this too. It's uncommon in today's world that we don't know somebody with diabetes.
Right.
It may not be an immediate family member, but it could be, an extended family member, a cousin, or a friend.
Could even be a coworker.
Exactly. The perfect example. And so knowing a little bit about maybe what they're going through and maybe helping us to all be, a better accomplice in this. Because I will tell you a funny story before I maybe get into answering your question specifically. But I have a very good friend. I hope he's listening or tuning in at one of these times. He is a physician. I won't maybe mention him by name unless he gives me the okay. But he's actually practicing now out in Idaho.
Okay.
And so I haven't seen him for, probably a decade. But we stay in touch through socials from time to time.
Okay.
But now he's a type 1 diabetic. And now this is an important distinction because, diabetes, most people are familiar with type 1, type 2. They may not be entirely sure of what those mean.
How it differentiates.
Exactly. But I guess we'll give you a quick tutorial on that. So type 1 diabetes, oftentimes called juvenile diabetes. This is actually an autoimmune disorder. This is something that sets in typically early in life when the pancreas gets attacked by antibodies. The body produces antibodies that destroy the parts of the pancreas that produce insulin. And so these folks are what's called insulin dependent. They will require insulin therapy in order to sustain. This is in opposition a little bit to type 2 diabetes, which is more of an insulin resistance that develops over time. Those folks certainly can be on insulin, but don't often require insulin early on, at least. So diet and lifestyle become paramount for type 2 diabetics, but certainly in type 1 diabetics, while lifestyle is obviously important too, it's certainly not going to be reserved just for that. But anyway, my good friend, he is a type 1 diabetic, and we were actually roommates in medical school during a semester where we were studying in Australia, which, by the way, we'll get maybe into some stories from that too as we go on. But we spent a semester in Australia, and we lived together. And I will tell you, I was the worst roommate. I was the worst influence ever. And
I've heard that from your wife, but
for sure, different reasons, but
different reasons altogether. But
but I feel so bad looking back because, to be fair, even as a medical student, my knowledge of diabetes was maybe more limited than it should have been. And so, we would be studying, because that's what we did all day in med school. You basically studied, and then you would go to class or to lab, and then you come back and you'd study some more. And so, social life was, we did our best, but we didn't have maybe a lot of free time. But anyway, Kyle and I would, sorry, Kyle, if you're listening.
We weren't going to mention it by name until we decided to mention it by name.
If you're listening, please
follow, subscribe, all those things. Thanks, Kyle.
But we won't give you a last name. How's that? So anyway, the cat's out of the bag now. So Kyle and I, we would sit there and study, and then come, 4 hours into this study session, I'd say, you know what, I want a milkshake. And then I'd look to Kyle and I'd say, hey, Kyle, you want to go get a milkshake? And then he'd check his sugar. He'd get out his insulin, give himself a shot, and so, all right, let's go. And so while I enjoyed those experiences significantly, Kyle, I apologize. I should have been a better friend to you. But the point is, though, again, that was coming from a medical student who maybe was still a little bit naive in diabetes as a global entity. But I had a lot to learn, and thankfully over time I have learned. And so now to dive back maybe into the original question, what's that conversation look like? Well, first is to make sure people understand what it is. What is this disease? What is this diagnosis?
Sure.
Right? And really, I guess in the most simplistic way I can maybe describe it is, it's where the body has a hard time using what you eat as energy. Everything we eat, drink, gets converted into energy, right? Mm-hmm. That's through our cellular mechanisms. So sugar, carbohydrates, they're going to be broken down in the body, and then the cells are going to have the ability to take that in to produce energy to sustain.
Sure.
And so as long as things are working fine, then there's really not a problem with that. But these cells, most cells in the body require insulin. And of course, thankfully, our body produces insulin. Mm-hmm. They require insulin to be able to take that energy into the cell, take that sugar into the cell to use it.
Okay.
Well, when someone develops diabetes, we'll say they all of a sudden now have a bouncer outside the cell, and it's saying, you know what, you're not coming in, right? You don't have your ID with you, can't let you in. And so what happens is that sugar stays in the bloodstream instead of being gobbled up by the cells, and it circulates through and through and through. And then now all of your organs are being exposed to a high concentration of sugar. And they don't like that. It's not supposed to work that way.
Right.
And so over time, that can actually damage the organs. And so when people hear things like diabetic nephropathy or diabetic retinopathy or peripheral neuropathy or all these opathies, right? These are a consequence, generally speaking, of sugars that have been too high for too long. And so that is really, I guess, at maybe the simplest way to put it, kind of at the molecular level, this is really what's happening.
Okay. I really appreciate you breaking it down in kind of simple terms.
Sure.
For somebody like me that can be simple from time to time. That having been said, what are some of the things that we can kind of look towards as far as, in essence, kind of preventative care, but also just maintaining a daily lifestyle of healthy choices to help us better navigate through a lifestyle with diabetes?
Yeah, great question. Because obviously, if someone gets diagnosed with diabetes, it usually goes something like as I can imagine being hit with a ton of bricks, right? This is not
Yeah.
something that anybody woke up and wanted to hear. Diabetes tends to come with, I don't know if stigma is the right word, but there's this sense that this is definitely a chronic disease that can have a lot of complications if not managed appropriately.
Mm-hmm.
And so certainly you have to, when you tell somebody that, it certainly I suppose relatively speaking, there's probably worse diagnosis that you can receive, but you at least have to be sensitive to that. This is going to be a life-changing thing to hear. But we try to reframe that a little bit into, this maybe is day one of the rest of your life as we start, gearing towards healthy living. And so that conversation will go something like, we have this diagnosis, right? We want to understand, I want to understand your understanding of diabetes, right? So we'll go through kind of that quick talk that we just had. And then we will break down into, okay, well, what's this mean from a lifestyle perspective? What's this mean for medications? You may be wondering, or a lot of questions, one of the number one questions I get is, do I have to be on medicine? Do I have to take medicine?
Right.
Right, and that's a big one. Well, the answer is, well, it depends. I mean, I would say for most people, as long as you have routine follow-up and we capture this relatively early on, the answer is no. You do not have to start medicine right away for most people. But, but then it's going to say, hey, we need to do definitely a relatively major lifestyle change here today. And that's going to be, number one, watching what we eat, right? And so understanding what causes sugars to elevate. Most people are probably aware that sweets, those are going to be something we want to limit, but maybe less commonly known are say simple carbohydrates. So like white bread and pasta, these are simple sugars that we want to try to eliminate. People will ask the question, can I eat fruit, right? Because fruit's sugar.
Right.
And the answer is I shouldn't say obviously, it's not obvious, but the answer is yes. Sugars are fruits are a complex sugar. And what that means is the body is going to expel energy to break that down. And that energy is going to last much longer too. So, there's probably not a great analogy I can use, but, we've all seen those, you give your kid a bag of Skittles, what happens, right?
Right.
It's an explosion of energy.
And then a big crash.
And then it's a crash, right? And that's what, simple sugars will do. They don't provide us a whole lot of nutritional benefit, and they don't sustain us.
Right. It's not sustainable.
Exactly. So having those complex sugars on board, and fruits certainly fit the bill. Whole grain, whole wheat type foods will certainly fit the bill. And so understanding that part of it is key. And while I don't want to maybe give, I suppose this is probably a good time to kind of disclaimer all this, right? Like this is general medical advice, and
right,
and shouldn't necessarily be confused as direct medical advice. See your doctor, but generally I'll tell someone that you don't have to. The idea is taking control without obsessing, right? Looking at labels maybe a little differently, but I don't necessarily expect a newly diagnosed diabetic to write down every single carb load, every single carb content of every label they come across. That can be exhausting.
Sure.
Now that's not to say that maybe in some cases it's a little more serious, right? If maybe we haven't been to the doctor in 2 or 3 years, we get this diagnosis, but now maybe our sugars are significantly elevated. Well, so to be fair, that may require a more dramatic change. But this, for the sake of this conversation, we're probably mostly talking about those who get diagnosed with relatively mild. And what does that mean? Well, there's something called a hemoglobin A1C. Have you ever heard of this term?
I have, but not enough to really recall and be able to describe it to somebody and say, hey, yeah, I know what that is.
Sure.
Let me tell you. I've got it written down. I got point 1, 2, 3.
For sure. Well, good news is this is one of the things in like the 12 years of training that I had that we learned, right?
Perfect.
What is an A1C? A1C, so every person has a certain percentage of their red blood cells that have sugar attached to it. That's the circulating sugar in the bloodstream is going to attach to those red blood cells. And that's going to give us a percentage, and we call that the hemoglobin A1C. And the higher, so this is like golf, right? We want a lower score, lower the better. We're not playing baseball here. We want lower scores. But an A1C of greater or equal to 6.5% is a diagnosis of diabetes. And certainly from there it goes up and up and up. But generally speaking, though, this is the other thing I tell people. The goal, your sugar goal, now this is going to be specific to the person, certainly, based on maybe other health factors at play, and
Okay.
age and activity level and all of those things. But generally speaking, if we can keep your A1C less than 7%, so understand this is still a diabetic range, but less than 7%, well, then generally speaking, we will not see a whole lot of those long-term health complications. And this is what I always tell people, we may have just received some bad news, but here's the great news. If you keep your sugar controlled, if you keep those A1Cs down into that range of controlled A1C, then you don't have a problem. You essentially don't have the disease. Now, that's not to say it's cured, because that's a question I get asked a lot too. Can I cure it?
Right.
Well, we don't necessarily like to use that term, because you're always going to be at risk, but can you more or less eliminate some of those long-term consequences?
Mitigate how it affects you.
Exactly. And the answer to that is, generally speaking, yes. You can more or less eliminate some of those long-term risks as long as you keep it controlled and you're mindful of it.
Okay. That's beautiful. Now, one thing I want to think about is, I know that there's different ways that people, I guess, I don't want to say develop, but maybe in their lives, there's going to be some people that I've known that have dealt with diabetes since childhood. Mm-hmm. There's going to be some people that I have known that get an onset later in life. I'm in my 40s, and I've known people that develop diabetes in their 40s, never had to deal with that before, and maybe they've had siblings that they've watched deal with diabetes, and suddenly they find that in front of them. One thing I want to think about, in regardless of whether you've had to deal with it from an early age or you're starting to deal with it at a later age, for one aspect, is there something that, kind of piggybacking off of our first episode with preventative care, is there something that can be done in regards to preventative care dealing with diabetes, and then also just kind of maintaining a lifestyle with or without diabetes, sure, to try and maintain a healthy lifestyle?
Sure. So yeah, absolutely. So, one of the things we do, or at least we should do on a pretty regular basis, is screen for diabetes. And that's through that A1C blood test. And generally speaking, at your physical every year, if you go to a physical, you'll get a blood test that should screen for this. And in some cases, you may actually be doing this blood test 2-3 times a year. Just it depends on the person and maybe what your own individual risk factors are. But we can identify prediabetes. And so prediabetes is, typically speaking, a normal A1C, so sticking with the A1C concept, say less than 5.7%. So if somebody comes in at 5.5, 5.4%, that's considered normal. 5.7 to 6.4%, this is where we kind of fall into the pre-diabetic range. And it's important to identify those folks when they get into that range, because these are certainly those that are going to be a little higher risk for developing. And maybe another kind of caveat, we'll say, one off that,
sure,
gestational diabetes. This is something that women are screened for during pregnancy, or at least they should be if they're getting, adequate prenatal care or antenatal care. But gestational diabetes is screened for because, A, we know that if a mother develops diabetes while pregnant, that can have some complications to the fetus.
Sure.
And B, gestational diabetics are about 50% likely to develop type 2 diabetes at some point in their life.
I did not know that.
And this is something, and I would say we want to bet a lot of folks probably don't know that. And I think this is something that is very big to get awareness out, because, and I shouldn't say the word obviously, but I think most people probably recognize that certain lifestyle factors can play a role in this. Obesity is a big one.
Okay.
Inactivity, even regardless of obesity, is another. Or just perhaps, family history by itself is another risk factor. So type 2 diabetes, this is what kind of separates, type 1 and type 2 also, is type 2 diabetes tends to be more genetically linked.
Okay.
Type 1 diabetes, interestingly, even though it happens generally speaking in juvenile or childhood, is actually not genetically mediated. And so that is something that was maybe not quite intuitive to me, when I was in medical school and training. So those three variables, weight, activity level, and family history, are probably the three most vital, frankly, for almost any chronic disease, but certainly in the case of diabetes.
That is amazing to know, because that's a lot of that brand new information for me. So I can understand, especially somebody having to learn as much as you had to learn through medical school, to just have kind of that naivete of,
Sure.
what it is and how it can affect people.
Sure, and I promise I won't bill you for this because this is
That's really appreciated.
But the point is obviously we're trying to raise as much awareness as we can.
Absolutely.
As a physician, and kind of going back, and we hope everybody tuned in to our last episode. But one of the goals of this show or this podcast was to try to reach as many ears as we could with some of this information that maybe it's not earth shattering, but we do think it's valuable. And I do think, one other thing too, I wanted to touch on. So this is kind of maybe a little known fact in diabetic management or diabetic care. One question I get asked a lot is, Doc, I went to bed, my sugars were good, right? I woke up, they were high. They spiked throughout the night. And I don't understand why, because I didn't eat anything, I didn't consume anything, I was just sleeping, right? So why? This is a great question when this comes up, because this touches on two kind of maybe relatively unknown principles, and one is called the Somogyi effect, and one is called Don phenomenon. And what do these mean? Well, so the Somogyi effect is actually more of a rebound sugar. So in someone with Somogyi, their sugars might actually be decreasing as they're sleeping. And they actually develop hypoglycemia, which, by the way, hyperglycemia can be very dangerous. Hypoglycemia can be acutely dangerous. We worry more about hypoglycemia in the acute setting. Hyperglycemia obviously is concerning, perhaps more long term.
Sure.
Not that there can't be maybe a threshold that's more acutely dangerous, but the point is, Somogyi effect actually is, generally speaking, someone who's developed hypoglycemia, and then their body goes into a little bit of a recovery mode. It says, no, this isn't good. We don't want this. And then you start producing what's called gluconeogenesis. The liver starts to produce sugar because it says, well, we need this. We need this to run. And the sugars actually spike because of that. So it's more of a rebound phenomenon. Now, Don phenomenon is a little bit different. So Don phenomenon would be more, your sugars may be doing okay, but as the body's getting ready to gear up for the day, it's sort of like, if you have your coffee maker set to start, 30 minutes before you wake up, right? The body's kind of doing that thing and saying, all right, hey, we need to gear up and get ready for the day because it's going to be a big one. So let's produce all of this extra sugar so we have it. Well, obviously that's not necessarily a good thing. But the answer there is typically that we need to be doing treatments to reduce the sugar for Don phenomenon, whereas in Somogyi effect, we need to be doing things to pull back a little bit on the treatment because we're causing sugars to dip too low. And I know that can be somewhat complex, and so we'd be happy to maybe touch on that in a different angle if anyone's out there like, wait, what did you just say? But one thing that can be helpful for both, though, and this isn't really an ad for continuous glucose monitoring,
right?
So we don't have any affiliations or anything. Not that we're not looking, but no, we don't get any.
Start getting sponsors that we can put on our shirts.
Exactly, be like NASCAR,
right?
But the idea is the continuous glucose monitors, which most people have seen. They're the little disc that goes in the back of the arm, or perhaps maybe even on the abdomen. Things like Libre or Dexcom are probably the two most common. These will help distinguish those two phenomenons because we are able to monitor in real time, in continuous fashion, what sugars are doing, so we can see trends better. In the old-fashioned days of pricking your finger and checking with a glucometer, well, one of the drawbacks is you kind of have to be awake to do that, right? And I suppose unless you have somebody checking while you're sleeping, which is a little creepy, but actually, which I guess I shouldn't say that happens a lot in pediatrics. So parents coming in checking their kid's sugar, and there's nothing creepy about that. By all means, you need to do that when you need to do it. But the idea, though, obviously, is if we can bypass that through continuous monitoring, right? We all carry around a phone. My daughter has a smartphone, and probably it's better than I am at using it. But she would have no problem with continuous monitors. The idea, though, is this technology exists, so should probably use it. Use it to your advantage.
Sure. And I think that even kind of circles back to our first episode of just general preventative care, and also getting to know, developing that relationship with your primary care physician to try and help monitor things and just be aware of what you're potentially going through and and how it can be then dealt with.
Yeah, keep your doctor in the loop. You know, if you're, I always tell patients when we make medication changes, for example, you know, let me know here in the next 2 to 3 days. You know, send me a message every day if you need to. Let me know how those sugars are trending, so that way we can make adjustments if we need to with medication. But obviously going back to our tips and tricks, generally speaking, if it's early onset, relatively mild diabetes, you can absolutely manage that with lifestyle alone. You just may need a little help on getting started, and there are lots of resources out there. Oftentimes we'll take a 30-minute conversation with me and my patient about this, but there are diabetic educators out there. There are nutritionists and dietitians out there. A lot of times we'll be covered by insurance, and so don't hesitate to use these resources when they're available to
Absolutely.
you, because they will save you headaches. They will save you lots of time in trying to figure it out. But yeah, don't hesitate to seek those resources when available.
Absolutely fantastic stuff. This is really just scratching on the surface, but I feel a lot more knowledgeable about the topic than I did even at the beginning of the episode. So I love the fact that this is something that we can get into and just get a general education on certain things that we hadn't really given too much thought to previously. Yeah. But understanding the importance of it really kind of brings it to the forefront and gives us a path to go on so that we can learn how to deal with these.
Well, no, I appreciate. Thank you. And that was the objective of this, right? It was to try to spread as much awareness. Now, I guess not to get ahead of ourselves too much, but I'm very excited about our next episode. I know, one of the things that we want to do with this is talk about a lot of bread and butter medicine.
Sure.
But we also want to dive a little bit off the beaten path and talk about some maybe more social, even psychological based issues. And again, things that I do deal with, a lot in my practice. So our next episode, for those interested, is going to dive into, why people give up on their dreams, right? And how to maintain motivation in the face of adversity. And I think that's going to be a good one. I think it's going to be great. And I think it's going to hit home even for us because, believe it or not, this idea to do this, it wasn't born yesterday, right? This was something that was a year.
We talked about it for many months.
And along the way, there were absolutely roadblocks, and there were challenges, and we had to overcome those. So we hope that if anyone's out there listening, we hope that that's something that may interest you. Feel free to tune in. Kyle, I'm very sorry. I was trying to go the whole episode without saying your name, but I hope you're doing well. But anyway, I'm Dr. Todd.
I'm Phil.
This is On Call Medicine. Thanks for tuning in. Until next time, live well.
Live well.